Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a minimally edited surgery. In this case, the Rhexis ran out. Let us see how I managed the case. This is the main incision with a 2.8 millimeter steel keratom. There is no leakage of aqueous, so I can make the side port after the main incision. You can do the reverse. First you can make the side port and then the main incision, doesn't matter. And now the anterior capsule is stained with trypan blue dye. I use an air bubble because the dye is not diluted by aqueous and the dye sits on the anterior capsule and the staining is very fast. I wash the excess dye and then in this case I used 2% hydroxypropyl methyl cellulose for maintaining the anterior chamber, to form the anterior chamber. And now I am doing Capsulorhexis and see what happens. I have been able to do Rhexis till now, it is okay. And now I am trying to do the small Rhexis, a mini Rhexis, and from here it goes out. I could not control it. Now what I could have done, I could have probably used high molecular weight viscoelastic substance like combination of chondroitin sulfate and sodium hyaluronate that could have enabled me to do small Rhexis successfully. However, it has happened and now how to manage. I am aspirating the cortex, decreasing the intralenticular pressure, and now I inject 2% recipients again, fill up the anterior chamber and make a small nick at the Rhexis at around 5 o'clock. And now I take the ureter forceps and go anti-clockwise and complete the Rhexis from 5 o'clock to 9 o'clock. The Rhexis has gone to periphery at 9 o'clock. And now the question is how to manage this. Should I convert to SICS? I tried this, pre-chopping this nucleus so that there is no pressure on the posterior capsule. Just going under the Rhexis margin and without applying any pressure on the zonule, without applying any pressure on the posterior capsule, I divided the nucleus into 2 heminuclei and then one heminucleus has been divided into 2 fragments. Now the other heminucleus is being divided into 2 fragments. Now this is not a very hard cataract. If it is a very hard cataract, we probably should not continue with phacoemulsification. We should go with convert the case to SICS. But this case the nucleus is not so hard and I have been able to divide the nucleus into 4 pieces. And now I decrease the bottle height and decrease the parameters, decrease the vacuum and flow rate. Irrigation pressure on the posterior capsule is lessened and now I continue with Phaco. I just go and pick up the pieces and emulsify very quickly. No, I don't have much time. I can't give a lot of pressure on the posterior capsule for a long time. You just have to finish it off as quickly as possible and it is done. And see, the cortex is also clean, there is no cortex in this case. So you just have to implant the intraocular lens The anterior chamber and the capsular bag is filled up with visco. And now here goes the intraocular lens. This is a hydrophilic acrylic single piece monofocal aspheric intraocular lens. And the leading haptic goes in the capsular bag and the trailing haptic is placed also in the bag. The leading haptic is at 7 o'clock and the trailing haptic is at 1 o'clock. And now I have to clean the visco thoroughly. At this time also I am taking care not to give pressure on the posterior capsule with irrigation. Just go and start aspirating, keeping the anterior chamber formed, keeping not making it shallow, but at the same time taking care that too much irrigation pressure is not there. And now I take the bimanual irrigation aspiration. Again the bottle height is low and I just go with irrigation and aspiration and irrigate and aspirate for some time and clean all the visco nicely. So once this is done, the case is done, we just have to close the side ports, make sure that the side port and the main incision is not leaking. This is moxifloxacin and the corneal stroma at the side port is hydrated. So the side port gets closed and now this is the final lavage of the anterior chamber. A nice lavage is done and anterior chamber is nicely formed. Then integrity of the wounds are checked by a cotton tipped Johnson bar. Few drops of moxie is applied over the cornea. The case is concluded. Thank you very much for your attention. There are many ways to manage when the Rhexis ran out. In this case, I managed continuing with Phaco.